Well, I want to welcome you to CHDV 460, which is Therapeutic and Medical Play Therapy. You are our summer semester course, and I want you first of all to tell all your friends to register for this course. I think we need at least 20 students in this course. And so we're a few shy. We need 5 more students. So tell your friends and to register. This is a fun class. It goes really quickly, and I think you're going to really enjoy the material and get a lot out of it. So to begin with, I'm Debbie Fingerhut. I am going to be your professor for this summer. This is a completely online course. We will have Zoom lectures and instructions, discussions, and activities on a weekly basis. And this first class meeting, unfortunately, I'm out of the country at my niece's wedding. So that's why you're seeing this in a recorded fashion. So again, this is a summer course. It's from 6 to 10 p.m. Although it's unlikely I will keep you that late. My office space is in engineering, office 510A. You can also reach me by phone. My phone number is listed here, 562-933-8061. This is also my direct email. You can also email me at dfinger4, symbol for at, calstatela.edu. Okay. All right, so the course description is you will be introduced to therapeutic and play therapy techniques that assist children and their families to overcome traumatic events like hospitalization, illness, injury, and so forth. There will be course lectures, readings, class activities, and assignments that will support your learning as you explore how short-term therapeutic interventions or play therapy and therapeutic play can provide tools for coping and resilience to children and their families. There is a required book. It is Therapeutic Activities for Children and Teens, Coping with Health Issues. It's in the bookstore. You can also get an online copy or digital copy. The learning objectives are listed here. I'm not going to read over them one by one. That's just too monotonous. Besides, you're all college students and you didn't get here by not learning to read, so you can read them yourself. Course requirements. There will be some readings every week. And so that's really only like 8 lectures because the midterm and the final, there is no lecture on those nights. You will have a good number of hours, like 6 to 8 hours within to take the midterm or the final. It will not take you much longer than 45 minutes to take the midterm or the final. There are only 25 questions. Okay, so if you look at the study guide for the midterm and the final, and you address some of the information in the study guide, you will be able to take the midterm and final in no time at all. The other thing is, as a gift, online coursework means that there is really no proctor for the exam. You can use your book, use your notes, use my slides. You can gather in groups for all I care. It is not to stump you at midterm or a final. It is a way to help ingrain some of the concepts of this course. So the more you can get out of it and retain from the midterm and the final, then I feel like I've done my job. So I want this to be an engaging and participatory course for you. And with that said, then there will be some discussions, 5 to be exact, the readings, of course. You will submit one of the 14 activities within the next month, so that I can just see that you've got everything, all the proper components, and that will help you to hit the ground running, because there will be 14 activities that you will not only complete yourself, not a child in your home, not something you've done previously, but you will create the activity that I demonstrate for you, and then you will write it up, and that we will go over the description, the write-up. Then you'll complete the midterm and the final exam online. And then lastly, you will turn in the portfolio paper at the end of the semester, the end of the summer. And that will have a cover sheet, a table of contents or index with all of the activities listed, 14 activities, their page numbers, and then each activity write-up and references, which is the book, okay? And that is worth 150 points. So you do not need to turn in any of the completed activities during the summer. Only the one activity write-up, and then the compilation of all 14 activity write-ups at the end of the semester. So what you will be doing, to be exact, is to complete an activity, take a picture of it with your smartphone, embed that in the on your paper, the top of your paper. You'll have the title of that activity. If it's, I will show you what one of the activities is for tonight. It's called an All About Me poster. You'll have the title, a picture. Sorry, I think I need coffee. The picture of the completed activity, and then all of the other 5 write-up components. So you'll need to turn in a sample of one of those write-ups in the next month, okay? That's the single project submission. I told you there would be 5 independent discussions. You will post your comments according to each discussion, what the discussions ask for, if it's talking about body image or a first grief experience or something like that. And then you will also reply to one other class member or 2 class members' posts. Sorry about that. It's right here, 2 class member posts. Attendance is required, so I will take attendance each week. And here is a normal write-up about instructional technology. We will be using Zoom, of course. A statement of reasonable accommodations. If you do have an accommodation, please make sure that I get a copy of that, so I know how to adjust the length of midterm or final. Academic honesty, please do your own work. Again, each activity is something that I need you to produce, not a family member, not a child, not someone you work with, if you work in a school setting, or something you've previously produced. Nothing that is produced online, so no pictures of things from online. I really want you to use your hands, and the object to that is I need you to figure out where producing the activity might have some tough spots. What if you have a difficulty holding a pencil or a pen? What if you aren't artistic? There will be no grades on artistic ability, but I do need you to actually complete each activity yourself, okay? Grading criteria, it's pretty straightforward. 50 points for attendance, 50 points, 10 each for the 5 discussions. The activity portfolio is 150 points. Activity submission, that single activity submission, huge a number of points, 50 points for that. But I need to help you hit the ground running so that you know where you need to beef up a section in the write-up, or where you what you need to do to correct all future write-ups so that your portfolio is pristine and gets top grades. Midterm is 100 points, final is 100 points, total of 500 points. And we use a grading scale with solid grades, pluses and minuses, okay? All right, so this is kind of our breakdown for the summer. So this first class is, it's of course a recorded overview of what to expect, going over the syllabus and the assignments. The reading, it's all in Rollins. It follows right through to from chapter 1 to chapter 13. We'll cover all of those chapters in the book in the 10 weeks ahead of us. There will be no lecture on the midterm, which is June 28th, no lecture on the final when the portfolio is due August 2nd. And this is it's kind of a, it's a really quick semester. I do think that there may be one additional week here, but if you don't mind finishing early, I'm out of town the following week. And that's, so I need everything to be turned in by Friday of this week, August. That would be probably August the 4th. Okay. But August 2nd would be the last day of class to turn in completed work and take the final exam. Okay. All right. So the first chapter, chapter 1, is about separation and coping. Before I kind of dive into that, I do want to share with you a little bit more about each activity. Oh, jeepers, I've stapled everything. Okay, so let me see if I can find the activity portfolio write-up. Okay. It's the portfolio paper description. So here it is. What I really want you to take note that where it's bolded here, the activity title, of course, the photo isn't bolded, but then you pop the photo in. The activity objective, I want that bold, please. Make it clear and concise, and make it align with the chapter. Okay, so in other words, separation and coping. If that's the separation and coping. The materials that are required for the activity, and I'll show you what an example of the activity will look like. The recommended age group, the age group that you feel the activity is best used with. Any special considerations, like if you have a young child that needs help with scissors, that's important. If you are using glue, and maybe it's a glue stick that's going to work better than actual drip glue or Scotch tape or something like that. Special considerations, safety considerations. You have to observe young children if you put markers in their hands, because the markers end up in their mouth. Then lastly is your subjective commentary, how you feel when you were completing the activity. It was easy for you, it was challenging for you, you weren't sure how to get started. No one has ever asked you how you felt about this, that, or the other. And so you know, those are the things that would go into a subjective commentary. Okay. Each activity is worth, what do I have here? Each activity is worth, oh, that doesn't make sense. It should be 5 points for each activity. Yeah, this is not correct. I need to change that. Each activity is worth 5 points. No, sorry, 10 points. And then the mechanics of the paper are the additional 10 points. Okay. This is worth 1/3 of your grade. And then the sample project submission is by the midterm or in the next month. I need you to submit one example of your finished activity, the title, the picture, the write-up, okay? All right, and that's, okay, that's wrong too. It's, all right, I gotta redo that, sorry. I have an example of a write-up. Here's an activity example. All right, so this is an actual picture of the origami crane that I made. It's on the table right behind me. I took the picture. I have the title, Origami Crane, the activity objective, creating a paper folded crane from paper is a cultural symbol of hope and is often represented in a garland of cranes given to an individual trying to overcome an illness. The age group, okay, school age and adolescents, materials used, the type of paper, safety concerns, paper cuts maybe, subjective commentary. I had a really tough time making this crane. It took me about 4 tries and a bunch of crumpled papers in my wastebasket. I just couldn't get it. So I ended up going to Google and looking for directions, like tutorials on how to create the crane, because it was not easy. But this will be one of your activities. I also want you to know that each of the activities are in your book. They are also written up, but there is much more information included in the book than I'm asking for. And I do not want you to pull anything straight from the book. This is the template for what I am asking, okay? Not everything else, all the rest of the superfluous information that is in the book. All right, so let's get back to the first lecture. This is about separation and coping, and there is a first activity associated with this, okay? A child's understanding of illness is the first slide, and this is all directly from your book. Meaning varies by age. A child's understanding of illness, it does vary by developmental age, cognitive ability, level of knowledge, like how many experiences they've had before, whether they were good or bad. From 2 to 7 years, their previous or perception of illness can be caused by external factors like magic, like, you know, the boogeyman, or, you know, something they did wrong. If they didn't clean up their toys, that's why they got sick or what have you. 7 to 10 years, they perceive illness to be caused by a person, an object, or an action. If someone sneezes on you or coughs on you, and that wasn't just an illustration, I actually just had a dry throat. And this slide needs another parenthesis too. Yep, that's where that should be. 13 plus years perceive illness as a malfunctioning of the body. So they have a more concrete understanding of how the body works and when something goes wrong. If you eat a lot of carbs, then yeah, you're going to get stopped up and get constipated, that sort of thing. So you are more in control over how your body functions, and the care that you take with your body feeds into your perception of what goes wrong. In hospitalization, some of the contributing factors to stress during hospitalization can be the length of stay, or being isolated from family and friends, like during COVID when visitors weren't allowed. If you have a fragile immune system, if you get sick a lot, if you have underlying medical diagnoses like asthma or diabetes, then that may make you susceptible to other ailments, normal flu season, COVID, so, those kinds of things. Children typically are not permitted to refuse treatment. So a lot of treatment and procedures and medication are prescribed, and children don't have much of a say in that. So there is a lack of control that is felt by children in healthcare. The surroundings are very unfamiliar. There's a fear of the unknown. And between the developmental stages of 7 months to 4 years of age, children are most vulnerable to their perceptions of why they're hospitalized. It's that age of fanciful thinking. What they don't understand, what no one has explained to them, they're going to conjure up an explanation that is 10 times far worse than reality. And another contributing factor to stress during hospitalization is when their dignity is threatened. If a physician comes in and says, let me listen to your heartbeat, and pulls up the shirt, in the playroom, that sort of thing, in front of other children, that is embarrassing. Or if they have to do some sort of procedure, an x-ray or something, and they're wearing a hospital gown, but it doesn't completely close in the back, and there's quite the draft, and they feel like they are not fully covered. Some variables that children, that we try to assess when we meet children for the first time, would be their developmental stage and their response to illness. And how we do that, we have to build a quick rapport with children and their families by asking, hey, my name is Debbie. I think this is your first hospitalization, and I would know in advance if I've checked the chart. Tell me, why are you here? So I need to hear it in the child's vocabulary, their explanation of why they're there. Sometimes children aren't told. Maybe the parents really desperately just want to get them in the car and get them to the hospital. They know their child's going to pitch a fit, and maybe they've actually said, well, we're going to Knott's Berry Farm or Disneyland, and they end up in the hospital. That is actually something that occurs when families just don't know. They don't have the words to explain, or they don't want to cause additional upset in their child. There's always a threat appraisal. Children associate pokes with going to the doctor, going to the hospital. They are fearful of what's going to happen to them and their body. So that's called a threat appraisal. So we have to dispel that. And when we introduce ourselves as child life specialists, we explain, oh my goodness, that's why you're here in the hospital. Well, my job is to tell you everything that's going to happen so that there are no surprises. Would you like that? And so I'm asking for approval from the child and family to be honest with them and tell them if there is something that might be difficult for you, like holding still, or maybe the nurse needs to give you medicine, and the medicine is too icky to taste, so it doesn't come in a pill form or in a liquid form, and they need to make a poke in your arm. I'm going to be right there with you and coaching you, so that it's a lot happier experience. Well, I don't want a shot, children say. You know what? Nobody really wants a shot, not even grown-ups, but I'm going to try to make it as comfortable as possible for you. And that's where we would use distraction techniques and other kinds of things to take their mind away. We have VR goggles so they can do something 3D, what have you, to not even know what is happening on their extremity or whatever. Gender. Boys and girls respond very differently to threat appraisal, to tension, stress. And so we have to be mindful that sometimes boys can be a little bit more physical, according to the literature. Girls tend to need more talking and explanations. And so we provide explanation to boys and girls. We provide active engagement so that they can touch, feel, handle medical equipment, ask questions. And so there's both physical and a cognitive verbal expression for both boys and girls. We assess temperament. If a child is pretty easygoing or super active or slow to warm, we have to assess all of that to know the best way to approach a child and their family. And then we ask about previous hospital or healthcare experiences. Were they okay? Were they scary? What was scary about that? And well, this is going to be different because I'm right here to share with you everything that will happen before it happens. And then coping styles. So we ask questions like, well, what do you do if you have to hold still? Can you be like a statue and be really still? Can you close your eyes or hold a hand? Can someone read to you? Can you watch a movie? We liken time frames to things that that a child may be interested in. You might have to hold still for as long as like one SpongeBob video, or whatever the latest cartoon character show is. And then family response and support. We're here to excuse me, to support the whole family. That's called family-centered care. And so we don't just zero in and focus on the child. We kind of embrace the whole family and support all of them and answer their questions and provide explanations that everyone can understand. There are some tables in your book, table 1.2, 1.3, 1.4, and so on. Excuse me. They are right here as well, table 1.1 through 1.5. They are also in the book, and they're really good tables to peruse for additional information. So I just wanted to make you aware of those. With a family, families define themselves. We have families with two dads and families with two moms and families with blended children from both previous marriages, or children with a new marriage. And we have aunties and uncles and grandparents parenting children. And so that family defines itself, and we have to figure out what the family composition is, who the matriarch or patriarch is in that family, and who we direct our attention to, who the decision maker would be for that child. And then we also zero in on brothers and sisters. We don't want them to feel pushed out of the picture. We want to include them They have just as many questions as their brother or sister who is in the hospital, and they need to know what's going on and have their questions answered right along with the patient and the parents. There are cultural influences that we recognize, different values and language. So we want to make sure that families feel supported in their primary language. Families that are in crisis, and usually when your child is in the hospital, we say that that is a crisis situation, because the hospital is a foreign place. It's not your home. It is it's a whole new set of rules, and you know, for however long a child is going to be in the hospital. So there are new policies and practices that the family needs to get to know, and we have to somehow marry that with what the family believes, what the parental beliefs are. And all of that kind of rolls up to the different cultures. In Long Beach, we have a very diverse cultural population. And so we want to be very mindful and accepting and compassionate toward families in whatever language or cultural influence that they subscribe to. Other family factors. There are financial stressors and social resource stressors. Sometimes there are diagnoses that families do not want their child to know about, especially if it's life-threatening. And so we have to respect that. It can be difficult for parents to be here as often as they wish to be, because if they are working, then they feel an obligation to continue to work so they have insurance coverage. And so they may be torn that they wish to be with their child in the hospital. And so then we're making a lot of phone calls to make sure that they're included in all of that communication. When we design activities for patients, we try to select something that is going to further that child's developmental and age-appropriate goals. Okay, so how we do that is we have to determine first the child's chronological and developmental age. We assess their temperament, their coping style. Are they right brain learners, left brain learners, visual or auditory learners? Again, their temperament style. We review their behavior, their child's behavior during stressful times. We ask them, what do you do when something is difficult or stressful for you in a challenge? What helps you the most, or what works best for you? And it could be having a family member there, having someone just close by that they can talk to and ask questions of. So we have to ask these questions so that we can really provide very individualized care and therapeutic activity for the child. We consider their energy level, their attention span, and then we determine whether or not we're going to do an individual activity session with the child in their room or in the playroom, or determine if they are a good candidate for an entire group activity session in the playroom. Some of our working guidelines with children involve developing that immediate rapport with a child. There is something called a campfire effect, which is a result of a shared activity as a focal point of interaction. And that shared activity engages children, focuses their attention on the completion of the activity, and takes the limelight off of each of them so that they can then feel like they can just talk or effervesce, you know, with their questions in a very natural, organic way. Children that are not in the spotlight tend to engage easier, quicker, more authentically than if they were put on the spot. So how we facilitate that is by defining the limits. You know, everybody's going to get a chance to share their completed activity. Everybody shares the materials and resources for creating that activity. If there's an issue with someone taking a little too long with a certain color pencil or scissors or what have you, then we will redirect, or we will get more scissors and more color pencils. We offer as many choices as possible, since choice and control are one thing that seems to be taken away when children come into the hospital. We reflect on their feelings. If they say, oh, I don't draw very well. Why do you think you say that? Because I don't know. I don't make a really round circle. Well, what could we do to make a round circle? Maybe we can take something round and we can trace around it to make it pretty exact. Oh, that's a good idea. So we explore their feelings and make sure that we're building them up and capitalizing on their strengths and their what they can do really well. There may be special activity considerations. If you have children with IVs in their dominant hand, then they're going to need help holding scissors and cutting and stapling and taping and drawing and all of that. So we have to help them and have their words guide us, and we help them complete their activities. And then what's really important is to thank children for participating in an activity and celebrating that completion or that accomplishment of completing the activity, and having them share what their activity is all about. Well, why did you make the sky purple? And why? Tell me a little bit about this right here. What is this green space? And let them describe their art. It's very intimate and private when a child shares their artwork and the concept behind their artwork, because it's a way for children to kind of like spill out all of their inner feelings onto paper or in a project. Some of the considerations we use in special diagnoses for emotional behavioral disorders, kids with hyperactivity, or they have aggressive behavior, they might injure themselves or have tried to injure themselves in the past. They may be a little withdrawn, they may be a little immature. They, because they've never handled some of the materials that we have available for them, or they may have learning difficulties. So these kinds of behaviors, when a child is also sick, they can be amplified. So we want to make sure we provide choices. We want to be very proactive with managing their behavior, explaining that that there's only 20 minutes left with their activity, then a 5-minute time frame that we will be cleaning up in 5. And if you do not finish your activity, I will make sure that you get all of the supplies to complete your activity, and we'll let you take those supplies to the room. We explain expected behavior, we set limits, we pay attention to warning signs. If a child is starting to kind of have a meltdown, then we'll redirect them quickly, and encourage new beginnings. You know, it doesn't destroy the whole day. Maybe the afternoon play session will be a little bit different after they've had a small rest. Children with autism and Asperger's syndrome, these statistics are a little bit dated. It looks like 1 in 80 to 1 in 240 children are on the spectrum. Well, it's probably more like 1 in 70 children are on the spectrum. The spectrum keeps getting bigger and more inclusive of a lot of diagnoses, from Asperger's syndrome to Down syndrome to autism to learning auditory processing disorders to all sorts of learning disorders, sometimes called pervasive developmental disorder, which is PDD. And these are all disorders that can be found in what is called the DSM. Oh, that's the dictionary, dang it. Sorry. The diagnostic criteria, it's called the DSM-5, and it will have a lot of different diagnoses. This is bipolar and related disorders and all of the medical codes. And under the spectrum, there are so many different disorders. It just becomes more and more and more inclusive of many diagnoses. So, oops. In the United States, 1 in 110 have a spectrum disorder. Autism is a developmental brain disorder that affects a person's ability to communicate, socially interact, and respond appropriately to the environment. You can be mild autistic, or you can be very severe autistic. So, and Asperger's is kind of on the high end of where you have a very high IQ. You may have you may not understand social, facial nuances. You may not understand sarcasm. You may have some social awkwardness, but you are very bright and can communicate. Children at a higher functioning level, Asperger's syndrome. Okay. So guidelines for working with children on the spectrum. We have to be aware of different stimulation in the environment. Lights, sounds, crowds, touch, things like that. So we want to give a child on the spectrum a lot of latitude, a lot of space, offer lots of choices in simple, clear instructions. Sometimes we have to use picture cards. This is what we're going to do first, then this, then this. And sometimes we have to mix them up and say, okay, tell me which one we're going to do first, just to kind of validate that they get it. We are super clear, concise, concrete with our instructions. We use simple images to illustrate the steps, provide transition cues from one thing to the next. Now we're going to stop using our markers. We're going to put them down, and we're going to put our hands on the glue bottle or the glue stick. Offer support for social interactions, kind of help them engage with other children in an activity room. And we kind of have to be aware of all the cues when children are going to have a meltdown, and maybe kind of hit that off at the whatever you want to call it, bite that, whatever it's called. If you want to head that off at the pass, I guess that's called. Children with brain injuries, we have to gauge whether a traumatic brain injury child can follow simple 1 or 2 step directions. We use a lot of repetition and consistency. We may ask same question over and over again, just demonstrating new tasks, avoiding figurative language, reinforcing the time frame involved for their attention to tasks. We probe skill acquisition frequently by, do you remember what we did yesterday? Do you remember what my name is? And if necessary, then they wear a little pad of paper on a lanyard, and we have to have them write things down, or we write things down for them as a review, so that we can start really building on their memory from day to day. We have to be prepared for reduced stamina and fatigue, and we need to keep the environment really safe and distraction-free. With abused, maltreated, or neglected children, we want to make sure that they feel emotionally safe. We remain approachable and patient and supportive listeners, communicating a protective presence. We might go over some rules that anything that is said in our activity room stays in the activity room, and you are safe in here. I am here. I'm going to protect you. Nothing that has happened to you has been your fault, because, as just an FYI for all of you, they're children. So grown-ups in the environment are, they're responsible for keeping the child safe. If the child was not safe in some situation, it is not the child's fault. We always believe the child when they disclose information to us. We show that we understand and we believe what the child says. We let them know that they can talk very openly to us. We validate their feelings. This is scary stuff. It is frightening. It makes me sad that you experienced that. And to just make sure that they understand this is not normal behavior. Adults in your environment are meant to protect you, and someone didn't. We affirm that children can confide in us. We assure them that they are never to blame. Even if they are provoking an adult, they are not to blame. They are a child. They are protected individuals. We need to stay calm when children disclose really private information, and we need to let them know that as part of their healthcare team, I need to let your nurse and doctor know what you've mentioned to me, and because we're all here to help. So that sometimes can break down the trust between child life and a patient, but it's honest, and I have to be honest with patients. So we provide positive feedback and reinforcement. We help them learn some conflict resolution skills through role modeling of what kinds of things might help them in the future, things that they can say, behaviors they can use. And we want to foster peer relationships from one child to another so that they feel empowered. In terms of disaster victims, and this is kind of setting the stage, mind you. There's a lot of information in this lecture, but it's setting the stage for what's to happen down the road with each chapter. And with disaster victims, there is a lot of separation. During any sort of disaster, car accident, a train derailment, an earthquake, what have you, children get separated from their family members. That's stressful. That requires knowing how to calm yourself and stay calm, and know that there will be adults in the environment that are there to help you. The American Academy of Pediatrics defines disaster as an event that involves injury or loss of life and destruction of property. Often what happens in, for instance, a car accident, if there are many people in the car and they're hurt, the children go to children's hospital. They're transported to the children's hospital. Adults may be transported to the nearest adult hospital. And so because of that, two things. Paramedics and ambulance, like EMTs, they don't overload one facility with all of the victims from an accident. They spread the wealth, because you're going to get better care if you are a trauma coming to the hospital and the rest of your family members are trauma cases going to other hospitals that can all deal with those traumas with the best of their ability, the best of their staff. If you send all, say, 5 family members to the same facility, it pretty much impacts that facility, and the 5th person coming through the door doesn't get the very best of care. And that should make sense to you. So children tend to be separated from family members. And if they're cognizant of what's going on, they're wondering what's happened to my mom, what's happened to my brother, what's happened to my dog, what's happened to my family, is everybody okay? So there is a lot of stress and coping issues that occur. Gender is a factor in response to disaster. Boys tend to display violent and aggressive behavior because they externalize symptoms and they display antisocial behavior. Girls tend to require a longer recovery period and display internalizing symptoms such as anxiety, mood disturbances, and are much more expressive than boys with their emotions. And this is all according to Pine and Cohen. Children respond to disasters in 2 distinct stages. The first stage, fear, disbelief, denial, grief, relief if a loved one is unharmed. These are stages of grief, really. It's like, you know, denial, disbelief. Those are stages of grief. It's like, oh my God, life just became altered. It will no longer be the same after this event. The second stage is developmental regression and manifestations of emotional distress, such as anxiety, sadness, and repressive symptoms. So once you get past the denial and disbelief of what just happened, you start to dig a little deeper into your emotions. You regress to an earlier stage of development where you have already mastered all of your milestones to kind of put the new situation way out here to figure out how you're going to deal with it, how you're going to get through the sadness and the anxiety of not knowing, of life changes, new routines, so forth. And before you can move through on that continuum, growth and development continuum, okay? So some tips for working with disaster victims. We indicate that we're available to listen. We use a calm tone of voice, get on the child's eye level. We follow the child's lead. So we don't give them any more information than what they are asking. We support the child's emotions and fears. We help them to identify their feelings, consider group projects so they can be among their peers. We design a range of expressive activities where they can push, pull, manipulate, press, punch like clay to kind of get some of that physical expression out of the way. With a lump of clay, you can punch it, you can push it, you can smash it, you can pinch it, that helps to kind of be somewhat cathartic with your emotion. And then, of course, we allow children to share their finished activity. Let's see. Okay, a couple more slides. Hang in there with me. Children with physical restrictions, we have to create a very accepting environment so that they feel included no matter what their restrictions are. We avoid assuming that a child cannot do something, because everybody can do something. If not, we can help them finish a project and be their hands or their eyes or what have you. We adapt materials and equipment as needed. And if necessary, we consult our rehab team to provide adaptive equipment. We find out what the child's strengths are and capitalize on them. We keep our expectations high and the child's expectations high. You can do this. I'm going to help you. You're going to finish it. You're going to be so proud. Think about which steps may be challenging for the child and then plan ahead. Let the child do as much as possible, but we can also be an extension to their ability to complete the activity. Some additional considerations: children who cannot play, you can play for them and have them guide you. Consider their age and developmental level, the materials that you choose, the toys, the techniques of the activity, and the child's condition. And then there are 3 stages of separation anxiety, according to Bowlby and Robertson: protest, despair, and detachment. Protest is when a child pitches a fit when their parent or caregiver is needing to separate from them. It's normal and common for a child to protest, to cry, to shake the bed rails, to really, have a meltdown. Despair is when they just realize, they're not coming back right now. My calling out, my protest was not effective. They kind of sink down in the bed and they just reassess. My nurse is really nice to me. She's really my friend. She is so sweet to me. So then there's a little bit of a detachment, and they kind of reattach to the immediate caregivers in their environment. A parent may return a couple days later, and the child prefers the nurse, wants the nurse to pick them up instead of the parent. That's normal. Those are the 3 stages of separation anxiety, and it's really important that you asterisk that. And then homesickness. It's the distress and functional impairment caused by an actual or anticipated separation from home and attachment objects, such as parents. It's the most prevalent type of distress experienced by hospitalized children, with more than 88% of our patients reporting homesick feelings. And they can have physiological impact on the child. Children can run a temperature, have real stomach aches and headaches, and feel like they're going to throw up. Being homesick has symptoms. So this is the activity goal for this chapter. It aligns with this chapter. It's not these 2 here. No, it's this one. Providing information which helps caregivers to engage with that child and quickly learn about their likes and dislikes. It's called an All About Me poster. I do not want you to use anything that you have used previously, like maybe you've done scrapbooking, maybe you've, I don't know, whatever it is, this is directly from the book, and this is not everything that I want you to include. Again, this is a lot more information than I'm asking for. It doesn't give you any extra points. In fact, it tells me you weren't listening if you include all of this. I do not want you to lift this information directly from the book. I want you to align the activity with the chapter. And I drew some pictures and I cut out some scrapbook paper, and you are not going to be graded as on any sort of artistic ability. This is all about me. I like sunshine. This is my child life family. My favorite color is purple, and I love spaghetti. Okay. It says these are a few. Oh, there are a few of my favorite things. I meant to write these. That's not good. Let me write these. There. These are a few of my favorite things. So this is an All About Me poster. When I complete it, I'm going to take a picture with my smartphone. I'm going to upload it. I'm going to have the title of the activity, a picture of my All About Me poster, can be very small. And then I'm going to have those 5 pieces of information. The objective, the activity objective, the materials that I used, a marker, glue stick, and construction paper. the appropriate age, and then any special considerations. I used a marker. If I was going to address this with a young child, I might have to help them with some of the writing if they don't know how to write or spell words. And my subjective commentary. Gosh, no one's ever really asked me about my favorite color, my favorite food, or what I like, and who I consider, you know, my home away from home family. So that's exactly what I want you to do for that activity. And that's what I have for our first meeting together. I want you to read through the syllabus. I want you to read through the instructions for the portfolio paper and the activity write-up. And then I will see you face-to-face on Zoom the following week. Okay. All right. And again, tell your friends we need about 5 more people in this class to make it fly. Don't worry, we will still have class with the 15 that are enrolled, but it is better with 20. Okay. All righty. That's what I have for you. Thank you so much.